All right, so hopefully now that you made it through Lab 1, you've gotten the basic idea of the rhythm of the class. So in an ideal world, you would have gone to Canvas already, and you would have printed out the Lab 2 sheet and have that in front of you so that you can take notes. So remember that in order to find that, you go to our course Canvas homepage, and you scroll down a little bit till you see the module that says Shoulder Girdle, and this one is going to be Lab 2 Myology. So what I'm going to do then is just run through that sheet, the origin, the insertion, and the action of each of those muscles. So a couple things to know about that sheet. The first thing to know is that the first page, which is the one that has the course title on it, where it says PEPROF 271, that's page 1. That page, you'll notice that there are 7 muscles, so there's a relatively small table on that page, and then there's a much larger group of muscles on the second page. So on that first page, where the course title is, all of those muscles are scapulothoracic muscles. So what that means is that each of those muscles produces one of those scapulothoracic actions that we talked about in lab last Thursday. So for example, remember that the scapulothoracic actions or movements are elevation and depression, protraction and retraction, and then upward and downward rotation. So each of the next 7 muscles, each of the muscles on that first page is going to produce some combination of those movements. So elevation, depression, that sort of a thing. And then all the muscles on the back page, so on page 2, all those muscles are glenohumeral muscles. So all of the muscles on the back page are going to move your arm. So those muscles then are going to produce actions like flexion and extension, abduction and adduction, and then internal and external rotation. So that's the way the page layout is set up. So if it's on the front page, then those muscles move the scapula, they're scapulothoracic. If it's on the back page or page 2, then those muscles are glenohumeral, meaning that they move your arm. Another little bit of terminology to be aware of. So there's 3 terms on there, or 3 pieces of information I want you to know about each of the muscles. So the first thing is the muscle's origin. A muscle's origin is typically proximal or close to the body, and that's essentially where the muscle starts. A muscle's insertion is usually distal or farther from the body, and that's where the muscle stops. And so generally speaking, in normal anatomical position, muscles are going to pull their insertion toward their origin. So muscles only shorten, and so when they do that, they typically pull the insertion toward the origin. And when they do that, they produce an action. So that action might be, again, flexion or extension, protraction, retraction, etc. So the other key thing to know then is where that action occurs. So if, and here I'm looking for either the joint or the articulation. So if we're talking about one of the muscles on the front page, where that action occurs is the scapulothoracic articulation. If we're talking about the muscles on the back, where that action occurs is at the glenohumeral joint. All right, so let's run through each of those in turn. So the first muscle that you'll see there is pectoralis minor. You've probably heard of the other pectoral muscle, which is pectoralis major. So we'll get to PEC major on the second page. So PEC major is a muscle that moves your arm. PEC minor, however, is a muscle that moves your scapula. So it's a scapulothoracic muscle. So you can see PEC minor there. Obviously on all these slides, the muscle that we're talking about, you'll see the name of the muscle there at the very bottom of the essential anatomy picture, and then that muscle will be highlighted for you. So in this case, PEC minor, or pectoralis minor, you can see the origin there that it originates along ribs 3 through 5. The way that the ribs are numbered is from top to bottom. So the rib that is closest to your head, the most superior rib, is rib number 1, and then we work our way down to 12. So ribs higher up have lower numbers, ribs farther down the body, more inferior, have higher numbers. So PEC minor then originates from the anterior surface of ribs 3 through 5, and you can see that it inserts there on the coracoid process. So when that muscle shortens then, what it's going to do is it's going to cause protraction of the scapula. It's going to pull your shoulder blade forward. But in addition to doing that, its other actions in addition to protraction are depression and downward rotation. One of the things I didn't mention early on is that PEC minor is deep to PEC major. So you probably kind of guessed that from the picture since PEC major isn't on there. But PEC minor is deep to major, so meaning that in order to see minor, you have to actually pull major off. So it's underneath that muscle. Another thing about PEC minor, I kind of alluded to it in lab last week, is that PEC minor is one that tends to cause problems clinically. So if you sit with muscles chronically shortened all the time, they'll actually lose length. They'll lose sarcomeres, and so the muscle becomes structurally shorter. And so PEC minor is one of the ones where people tend to kind of sit, hunched over their computers. And when you do that, your scapulas are resting and in protraction, or you're resting with your scapulas in protraction, which then can lead to a chronically shortened muscle that can then become structurally shorter. Where that's a problem is because PEC minor is a depressor and a downward rotator. If you try to reach overhead, so you need to then upward rotate and elevate the scapula, you can't do that. Those are the opposite of the actions that PEC minor performs. And so sometimes when people have shoulder problems, one of the significant underlying issues is that pectoralis minor is too stiff or short. And so as part of the rehab program, one of the things that we'll do is work with them on lengthening that muscle. So that's PEC minor. And then the next one is serratus anterior. So serratus anterior, you can see it there. It's named for its appearance. So if you think about a serrated knife, like a steak knife that kind of has jagged edges, because of the way that this muscle appears, that's where the name comes from, kind of those jagged edges that you can see there, where it appears kind of like a serrated knife. And it gets that appearance from its origin along ribs 1 through 8, again starting up here at the top and working our way down through the next 7 ribs beyond that, so ribs 1 through 8. It actually goes up underneath, or on the anterior aspect of the scapula, and inserts along the medial border of the scapula. So I mentioned last time in lab that the scapulothoracic articulation, the reason I'm using that term is because it's not a true joint. There's no direct bone-to-bone connection. And instead, there's a muscle that sits between the anterior surface of the scapula and then the posterior surface of the ribs. Specifically, that muscle is this one. So that is serratus anterior. So it's the one that sits between your scapula and your rib cage, making it the scapulothoracic articulation. But because it runs from kind of on that lateral aspect of your rib cage up underneath the scapula, its primary action is going to be scapular protraction. It's going to pull your scapula forward. And then its other action, because of the angulation of the fibers, it's also an upward rotator of the scapula. So the two actions then, protraction and upward rotation. This is an important muscle if somebody's got shoulder pain, let's say a baseball pitcher or somebody like that. One of the things that we're going to do is work on their upward rotation strength to try to offset some of the possible shortness of pectoralis minor. And so we will work on the strength of this muscle of serratus anterior. The next one then is the smallest of our muscles, subclavius. So its name tells you where it sits. Again, sub means below, clavius is clavicle. So subclavius sits below your clavicle, and it's even kind of hard to see highlighted. So you can see this little yellow muscle there. That's subclavius. It doesn't do a whole lot. It's not really involved clinically very often. But you can see the origin there, which is the costal cartilage of the first rib. One of the things I haven't told you is what the costal cartilage is, but you might have noticed when you look at the skeleton on the Essential Anatomy app that his ribs don't actually connect to his sternum. Remember that the sternum is the bone in the middle of your chest, and then you'll see a gap there between the end of the rib and the sternum. Of course, none of us have a gap there. Instead, we have cartilage that connects the ribs to the sternum. Trying to get my mouse back, there it is. So we can connect the ribs to the sternum via hyaline cartilage, which is called the costal cartilage. Costal means rib. So anytime you've got costal something or other, there's ribs involved. So for example, actually the muscles that you can see on the app here or on this picture, those are your intercostal muscles. So they're muscles that run between the ribs, and those are going to be involved in breathing. We'll talk about those when we get to the respiration chapter. But at any rate, for now, subclavius originates from the costal cartilage, so that cartilage, on the first rib and inserts there on the inferior surface, so underneath on the clavicle. So all that it really does is help stabilize your clavicle, help stabilize the sternoclavicular joint, and in terms of major actions, it's going to be a depressor of the clavicle. So it's going to cause depression at the scapulothoracic articulation. But as I said, not often involved clinically, so not a whole lot going on there. One muscle that is often involved clinically, though, is this next one, which is levator scapulae. So levator, the name tells you what it does. So it elevates. So what it's going to do then is going to elevate your scapula. It's going to bring your scapula closer to your head. It's going to perform that shrugging motion that we demonstrated in class last week. So levator scapulae, you can see the origin there, the transverse processes of C1 through C4. What does that mean? Well, a couple things are going on there. Number one, in terms of your spine or your vertebral column, there's 3 sections to your spine. The most superior section, so the top section of your spine, is called the cervical section. So that's your neck. And then the middle section of your spine, which interacts, those bones interact with a rib, each of them interacts with a different rib. That is your thoracic section. And then the bottom section, the most inferior section, which is in your low back, that's the lumbar section. So cervical in the neck, thoracic in the middle, and then lumbar in the low back. There's 7 vertebrae in the cervical section, 12 in the thoracic section, and then 5 in the lumbar section. So if I want to talk about a specific bone in one of those sections, what I'll do is indicate which section of the spine that it's in by using the letter of the section. So C for cervical, T for thoracic, L for lumbar, and then I'll indicate the number of that vertebrae or the number of that bone from top to bottom. So the most superior cervical vertebrae is C1, continuing down to C7, which is at the very bottom of that section, T1 to T12, L1 to L5. So in this case, levator scapulae originates from the top 4, the most superior 4 cervical vertebrae. The transverse processes are projections from each of those vertebrae that poke out to either side. So you have a right transverse process and a left transverse process. And given the muscle layers here, you can't actually see the transverse processes, but you can see the spinous processes. So actually this is one down here near C7, or this is C7. So you can see this really obvious little projection that pokes posteriorly on these vertebrae. So those are the spinous processes. You have similar projections that poke out again to either side. Those are the transverse processes. So levator scapulae then originates from the transverse processes of C1 through C4, and then as you can see there, it inserts on that superomedial border. So again, superior angles here, all of this is the medial border, so it inserts on that superomedial border of the scapula. And in terms of actions, again, it tells you its primary action is right there in the name. It's going to be elevation, and then the other action is going to be downward rotation. So that's its other job. This muscle is deep to trapezius. So if you feel on either side of your neck, most people have a fairly thick muscle more posteriorly near your back. Those are your traps. You're probably already aware of that muscle. So levator scapulae is actually underneath that. It's deep to that. So this is one that holds up your scapulas all day long and tends to get knots or trigger points in it, which tend to cause pain if you actually mash on the muscle, or sometimes when somebody's just standing there, they'll have neck pain and that kind of thing. That can be the result of dysfunction in the levator scapulae muscle. All right, moving down a little bit. Then we've got our rhomboid major and rhomboid minor. The way it's laid out on the sheet, I've got rhomboid major first, so we'll take that one first, even though it's the more inferior of the two. So rhomboid major, its origin is the spinous processes of T1 through T5. So again, T stands for thoracic, and again, in terms of the structures, those little bones that poke straight out toward the back or straight posteriorly on your spine, those are the spinous processes, the most posterior projection from each vertebrae. So the rhomboid major muscle then originates from T2 through T5, so near the top, effectively, of the thoracic section, and then it runs from those spinous processes laterally to the medial border of the scapula here. So one of the things that I want you to notice is that medially, the origin is more superior to the insertion laterally. The reason that matters is because one of the actions of rhomboids, both major and minor, is going to be downward rotation. They're going to tilt the scapula down. But in addition to that, their other action is going to be retraction. So that's rhomboid major. Rhomboid minor does the same things. It just has a different origin, same insertion. So rhomboid minor originates from C7, so the most inferior cervical vertebrae, and then T1, the most superior thoracic vertebrae, also inserts on the medial border of the scapula, and it is also both a downward rotator of the scapula and then a retractor. So it does the same things that we see with rhomboid major. All right, and then we get to the big guy on the upper back, which is your trapezius. So your trapezius, as you can see there, is the most superficial of the muscles, so it's the closest to the skin surface. You can see it's a pretty big muscle. It's actually usually broken into 4 different sections, and I'll talk about each of those in turn. So in terms of the origin, because it's such a big muscle, it has a fairly large origin. So you can see that the origin starts up here at the base of the skull, an area called the occiput. So you'll notice if you feel the base of your skull in the back, you've got a pretty obvious knob back there. So it's going to originate from that most posterior and inferior bone on the posterior aspect of the skull. So it originates there from the occipital bone or from the occiput, and then its origin runs along something called the ligamentum nuchae. And so what the ligamentum nuchae is this ligament that runs from the base of the skull down to C7. And I'm kind of moving my mouse along where the ligamentum nuchae would be. It's a connective tissue structure that if you look down at the ground and feel along the midline of your neck, you'll notice there's something that feels kind of like a cord there. That's the ligamentum nuchae. And if you go from looking straight at the floor to looking straight up at the ceiling, you'll notice that goes away. And effectively, obviously, it's still there. But effectively, what happens is when you look up, when you extend your neck by looking up, you're going to put some slack in that connective tissue. And so then it becomes easier to palpate through it, and you can actually feel the underlying bones. You can feel the spinous processes of the cervical bones whenever the neck is an extension. So your traps then originate from the occipital bone, from the ligamentum nuchae, and then from the spines of vertebrae starting C7, so the most inferior cervical vertebrae, all the way down through T12. So effectively then your traps run from the base of the skull all the way through the entire thoracic section of your vertebral column. So really big origin there. In terms of the insertion, really big origin, tends to have a really big insertion, not always, but oftentimes, and this is one of those cases. So there's a pretty long, or broad I should say, continuous origin, so it's insertion, pretty long continuous insertion along the acromion. So remember that your acromion is the tip of your shoulder, so it's out here, as well as the spine of the scapula posteriorly, and then the distal third of the clavicle anteriorly. So again, pretty broad insertion there. So in terms of the actions, again, and this is in the slideshow if you pull up the PowerPoint that's on Canvas, but essentially it's oftentimes broken up into 4 sections. And you can kind of see the way the fibers run. So effectively the top section, or section 1, are the fibers that almost run straight up and down. So section 1, these top fibers where I'm moving my mouse, their only action is elevation. Now when we come down a little bit further, you've got some fibers that are angled at about 45 degrees, kind of in through here. This is section 2 of the traps. So when we get to those fibers where they're angled at about 45 degrees, those are still elevators. Section 2 still does elevation, but it also does retraction, so it pulls your scapulas posteriorly, and then it does upward rotation as well. Section 3 is where the fibers run basically horizontal, and so section 3 is in through here, kind of this middle part. And so the only action in section 3, no rotation there, no elevation, all you're going to get there is straight retraction in section 3. And then section 4 are these most inferior fibers down here. So because of their relationship between themselves and their insertion here on the spine of the scapula, section 4 is actually also going to cause upward rotation. And then you get retraction and depression as well. So one of the interesting things about traps is that traps does antagonistic or opposite actions. So traps is both an elevator and a depressor. Those are opposite or antagonistic actions. Muscles typically don't do that. So if you're going to guess a muscle's action, try not to guess 2 things that are in opposition to each other. Generally, muscles aren't both flexors and extensors. Occasionally some are, like deltoid will be, but for the most part they do one or the other. So traps is one of those rare ones that does antagonistic things. In this case, both elevation and depression. In addition to that, so the other thing I'd want you to remember is that sections 2 and 4 are your upward rotators, and that sections 2, 3, and 4 are all going to be retractors. Section 1 is not, it's only an elevator. So having gotten through traps then, so that's the first 7 muscles on that sheet, that's all the ones on that front page. So we've gotten through then all of the muscles that are that interact with the scapulothoracic articulation. So those are all the muscles that move the scapula. For the rest of the slides, Then we're going to be on the glenohumeral joint. So all of those muscles are going to be ones that move the arms. They're all glenohumeral muscles. So moving on to the second page, to the back page there, you'll notice that the first muscle is pectoralis major. So PEC major is one that people tend to be familiar with. You can see PEC major there, because it's your big superficial chest muscle. So because it's such a large muscle, it does have two sites of origin. It originates both along the sternum and along the clavicle. So the origin technically is the sternal end of the clavicle, the sternum, and the costal cartilage of ribs 1 through 6. And so it has, sometimes people refer to those as two heads. It doesn't have two heads in the name, but sometimes people will talk about the clavicular head of PEC major and then the sternal head. Sometimes you see that in like bodybuilding type literature, where they'll talk about if you do presses that are like overhead or at like incline presses, those kinds of movements tend to work the clavicular head more, as opposed to things that are more like on a flat bench or a decline bench. Those tend to work the sternal head a little bit more. So that's where you might have encountered those terms. But either way, all those fibers come together. They have one common tendon of insertion into the intertubercular groove of the humerus. So remember last time we talked about the bicipital groove or the intertubercular groove, which is that space between the lesser and greater tubercles of the humerus. So in the case of the intertubercular groove and the muscles we're going to talk about today, there's three muscles that are going to insert along that groove. So those muscles are pectoralis major, latissimus dorsi, and then teres major. And the order that I just gave them to you in is the order that they run from lateral to medial. So pectoralis major inserts on that most lateral aspect of the intertubercular groove. And so in terms of actions, the actions of PEC major at the glenohumeral joint, it's a flexor, an adductor, and an internal rotator. So flexion, adduction, and internal rotation for PEC major. Then the next one, we got a fairly small one. So we've got Coracobrachialis. So Coracobrachialis tells you where it originates. It originates from the coracoid process. It also tells you where it inserts. Anything brachial deals with the upper arm. So Coracobrachialis runs from the coracoid process of the scapula, that's the origin, and it inserts on the medial surface of the humeral shaft. So in terms of the actions for Coracobrachialis, really there are two that we're going to concern ourselves with, and those are flexion and adduction. So the two actions for Coracobrachialis, flexion and adduction. This is probably a muscle that you weren't aware existed. The only time you might have ever noticed this muscle is if you went and did something like lots of bench press, lots of push-ups, various other, an overloading of lots and lots of pushing motions. And if you felt that there's a soreness kind of behind your biceps medially, that's where Coracobrachialis is. So it's, again, a pretty small muscle. You can palpate it, meaning you can find it if you poke around, but it's easiest to find if somebody's sore there, which again, typically you're going to get with pushing motions because that is flexion. So again, flexion, adduction for its actions. All right, and then next we have Subscapularis. So Subscapularis is one of the muscles of the rotator cuff. There's going to be 4 of those muscles, and Subscapularis is the first of the 4. So Subscapularis originates from the subscapular fossa, so essentially that entire anterior surface of the scapula, and it's going to insert on the lesser tubercle of the humerus. So you can see it highlighted there. If you're going to pull the insertion on the humerus here toward the origin on the scapula there, the action is going to be internal or medial rotation. So the action for Subscapularis is internal or medial rotation. We'll talk here in a minute in more detail about what the rotator cuff does in addition to actually causing rotation. It has a really important role in stabilizing the glenohumeral joint. But for now, just know that Subscapularis is the only internal rotator of the 4 rotator cuff muscles. Then we have biceps. So it's biceps brachii because there is another biceps. One of your hamstring muscles is biceps femoris. So you got to be specific. We got to say biceps brachii so that we know that we're talking about a muscle in the arm, not a muscle in the posterior aspect of the thigh. So biceps, bi means 2, seps is heads. So biceps has 2 heads. There's a long head and there's a short head. And what you'll notice here in the Essential Anatomy app is that you can only click on one or the other, or at least I've only been able to figure out how to click on one or the other. You can't highlight biceps as a whole. So the first picture that you see here is the short head of biceps. So short head of biceps originates from the coracoid process along with coracobrachialis. So those are two muscles that originate there at the coracoid process. So that's its origin. Both of the heads of biceps run together and insert into the radial tuberosity, or the tuberosity of the radius. So you've got the short head pictured for you there, again originating from the coracoid process. The long head, now that one's highlighted. The long head originates from the superior aspect of the glenoid. So remember talking last week about the glenoid cavity or the glenoid fossa. The long head originates from an area called the supraglenoid tubercle, so just above the glenoid. And you can see it has a really long tendon. There we go. So there's its long tendon that runs in the intertubercular or bicipital groove. Those two heads come together. Again, same tendon of insertion into the tuberosity of the radius. Last time we talked about impingement syndrome, and I mentioned that biceps is one of the things that tends to get impinged. And you can see the long head of biceps here underneath the acromion being right here. Here's your clavicle, the acromial end of the clavicle. Here's the actual acromion. So biceps is one of the things that can get pinched underneath the acromion. So again, those two heads run together, insert into the tuberosity of the radius. Biceps has, at the shoulder, biceps has a couple of important actions. The first is that it's a flexor. So biceps is going to bring your arm straight forward. And then the second thing is that it does horizontal adduction. So that's kind of like a fly motion if you're in the gym. So we haven't really talked about the horizontal motions. So for now, at the glenohumeral joint, just remember that biceps is a flexor at the glenohumeral joint. Then we got our deltoid. And deltoid, one of the things I would tell you about it is if you are looking for a muscle that does something, if there's a question on the Canvas exam about the glenohumeral muscles, and it's asking you about a muscle that performs a certain action, if deltoid is an option, definitely pick deltoid because it's one that does almost everything at the glenohumeral joint. So you can see deltoid, kind of like traps, has a fairly broad origin. So it's also going to originate from the lateral third of the clavicle, also along the acromion, and then the lateral third of the spine of the scapula if we wrap it around back. So it runs from, again, basically the lateral third. So lateral third of the clavicle, all along the acromion, lateral third of the spine of the scapula. And then, so effectively with deltoid, people oftentimes refer to it as having three parts to it, not necessarily three heads, but three parts to it. So effectively there is an anterior aspect, which are these fibers here in the front. There is a lateral or middle aspect, is what people call that sometimes, and then there's a posterior aspect back here. So all three of those sections come together and have a common tendon of insertion down here into the deltoid tuberosity. So the anterior section of the deltoid, the primary action there is going to be flexion. So anterior section does flexion, and you don't need to know the sections differently, but I think it makes it make a little bit more sense because again, deltoid is going to be one of those ones that does antagonistic actions. So these more anterior fibers that I'm mousing over, those are going to be the fibers that cause flexion. The fibers in the back, the posterior fibers, are going to cause extension, and then these middle fibers are going to cause abduction. And then if we activate deltoid anterior to posterior, we can get external rotation or lateral rotation. If we activate deltoid posterior to anterior, we can get internal or medial rotation. So deltoid then is active in both abduction, flexion, extension, and then internal and external rotation. So it does 5 of those 6 actions that we talked about when we discussed the motions of the glenohumeral joint last time. So like I said, if you're going to pick a muscle, you need to know a muscle that does a specific action at the shoulder. Pick deltoid because it does pretty much everything. So pretty active muscle. Then we've got our next rotator cuff muscle. So this muscle is supraspinatus. So you can see that supraspinatus originates from the supraspinous fossa. So again, supraspinous means above the spine. So there's the spine of the scapula. So the supraspinous fossa is that taco area just above the spine of the scapula. So supraspinous fossa, or supraspinatus originates there, and the supraspinous fossa inserts on the greater tubercle of the humerus. So remember we talked about that the greater tubercle is this whole lateral aspect here on the proximal humerus. So you can see where supraspinatus inserts there. So in terms of actions, supraspinatus, its primary action is going to be abduction, but it also plays a role in flexion as well. I mentioned on the last slideshow that supraspinatus is the most commonly injured of your rotator cuff muscles, again, primarily because of where it sits. So because it runs directly underneath the acromion here, it's one that tends to get impinged or crushed between the humeral head and the acromion, so it tends to fray as we get older and we lose some of our scapular motion. So it'll fray and tear. So if you know somebody that's had a rotator cuff repair, most of the time that's a supraspinatus tear that's been repaired. The second most commonly torn is our next muscle, which is infraspinatus, which is down here. Speaking of infraspinatus, there it is. So you can see infraspinatus runs from the infraspinous fossa of the scapula also to the greater tubercle of the humerus. So it's actually going to kind of wrap around the posterolateral aspect of the bone. So it wraps around the back and the outside, inserts there on the greater tubercle. And so if we pull the insertion there toward the origin, we're going to get external rotation. So its action is external rotation. And then the last of our rotator cuff muscles is our teres minor. So you can see that teres minor originates from the lateral border of the scapula. So it runs from that lateral border there, also inserts on the greater tubercle. So 3 of the 4 rotator cuff muscles, as I mentioned last time, insert somewhere on the greater tubercle. In sports medicine programs, sometimes they'll refer to, if you want to consider the insertion of the rotator cuff muscles, the acronym they'll use is SITS, so S-I-T-S, because using that acronym, it runs from supraspinatus, so most superiorly, supraspinatus, infraspinatus, teres minor, and then if we wrap all the way back around to the front, or the anterior aspect, then you've got subscapularis there that's going to insert on the lesser tubercle. So remember, subscapularis on the lesser tubercle, the other 3 are on the greater tubercle, and they run from top to bottom, supraspinatus, infraspinatus, teres minor. So teres minor, just like infraspinatus, is also an external or lateral rotator of the shoulder. So the important thing to know then about the rotator cuff is that this slide, I know the view is a little bit weird because of the window that I picked to record on the screen, but things to know from this slide is actually one that I stole from the slideshow that's up in Canvas. So if it looks a little bit weird, don't worry about it. The same slide is up in Canvas. The gist of it is there are 4 rotator cuff muscles, and those 4 muscles are supraspinatus, infraspinatus, teres minor, and subscapularis. But this part you can see. So remember that I mentioned that deltoid is involved in pretty much every action at the shoulder. So abduction, flexion, extension, rotation, deltoid does almost everything. And because of where deltoid runs, that it runs from the clavicle, the acromion, and the spine of the scapula, all those heads come together and they insert there at the deltoid tuberosity. In almost any arm motion, the first thing that you're going to do is you're going to contract the deltoid. Well, not only does deltoid produce that abduction motion or flexion or whatever it is that you're trying to do, but deltoid, because you're going to pull the insertion down here on the deltoid tuberosity up toward the origin, let's say at the acromion, what deltoid is going to naturally do is actually slide the humerus up. So deltoid, every time we activate it, it actually tends to close down that subacromial space, or the space underneath the acromion here. So to keep from impinging the structures under there, that's going to be one of the jobs of the rotator cuff. So before we contract deltoid, we actually activate the 4 muscles of the rotator cuff first. And so they're going to contract milliseconds before the deltoid does. And when they do, so this is the line of pull of supraspinatus here, this is the line of pull of subscapularis there, and there'd be a similar line of pull on the back for infraspinatus and teres minor. And what those rotator cuff muscles are going to do then is they're going to pull the head of the humerus against the glenoid. And by doing that, they're going to convert that upward slide that deltoid would tend to cause into more of a roll and an inferior slide here. So basically the job of the rotator cuff muscles then is to pull the humeral head against the glenoid and maintain this space underneath the acromion to keep us from getting impinged. And we tend to get impingement both when we have tightness of some of those downward rotators that we talked about of the scapulothoracic joint, or weakness of the upward rotators, or when the rotator cuff muscles themselves get weak or fatigued. Because when they get weak or fatigued, they get less good at being able to maintain this space. So a weak or fatigued rotator cuff is something then that can also play a role in impingement. The other thing that the rotator cuff does, as you probably would have guessed, is because they pull the humeral head against the glenoid, they help stabilize the glenohumeral joint. So if you've ever had problems where you have an unstable shoulder, or you've dislocated your shoulder before, or anything like that, you've probably done rotator cuff exercises where you rotate internally, you rotate externally using bands and various other things. And the reason you're doing that is you're trying to strengthen those rotator cuff muscles to help both increase their strength and also thereby stabilize the glenohumeral joint as well. So they play a really, really important role in stabilizing the glenohumeral joint. So those are our rotator cuff muscles. Moving on from the rotator cuff, the next muscle is our latissimus dorsi, known more colloquially as your lats. It's the one that gives you that sort of a V shape when you do things like pull-ups, or if it's well defined, give you kind of that V taper to your torso. So latissimus dorsi, as you can see there, pretty big muscle, because the big muscle has a really big origin. So you can see it attaches via the thoracolumbar fascia, which is this white stuff right here. Thoraco, again, deals with thorax, lumbar is the low back. So thoracolumbar fascia is this fascia that connects the low back and the lumbar spine to the lats, but it also then, and you can't really see it in this picture, but if you add some more layers, you should be able to see some more fascia continuing on into the pelvis. And so basically what the thoracolumbar fascia does is it transmits force from, let's say, the left leg to the right upper extremity. So if you pay attention when you walk, whenever you extend your left leg, you also extend your right arm. So opposite motions. So the thoracolumbar fascia plays a role in transferring force from the lower body to the upper body through the low back. So in the case of latissimus dorsi, it arises from the thoracolumbar fascia and includes the lower six, or the spines of the lower six thoracic vertebrae, so through here, all of the lumbar vertebrae, so through the entirety of the lower back. It attaches to the bottom 3 to 4 ribs through here, and then also to the iliac crest over here, which is part of your pelvis. So again, really broad origin. This one does have a pretty small insertion though, so the insertion, it actually wraps anteriorly, so it goes in front of the humerus, and inserts on the intertubercular groove. So I talked about PEC Major, Latissimus Dorsi, and Teres Major all inserting on the intertubercular groove, and you can see that here with lats. So it's going to move from posterior to anterior. And the reason that matters is for rotation. So whereas Infraspinatus and Teres Minor wrap around the posterior aspect of the humerus, Latissimus Dorsi and Teres Major are going to go on the anterior aspect. So muscles that, like latissimus, that move from posterior to anterior are going to be muscles that cause internal rotation. So latissimus dorsi is going to cause internal or medial rotation of the glenohumeral joint. In addition to that, it's also an extensor and an adductor at the glenohumeral joint. So then after latissimus dorsi, we're in the home stretch now. So we've got Teres Major. So remember, this little guy right here is Teres Minor. Teres Major is just below it. Teres Major, as you can see there, arises from the inferior angle of the scapula and that posterior surface. So the inferior angle of the scapula there also inserts along that intertubercular groove, and if it helps, it does the same 3 things that your lats do. So Teres Major is also an extensor, an adductor, and an internal rotator. So same stuff that lats does, just not nearly as powerfully because it's not nearly as large of a muscle. And then last, but certainly not least, is our triceps. So if biceps means 2 heads, triceps means 3 heads. So of triceps' 3 heads, only one head, which is the one that's highlighted here, which is the long head, is going to cause, or only one of the heads actually crosses the glenohumeral joint. So again, that's the long head. So the long head then arises from something called the infraglenoid tubercle. So you're familiar with the glenoid, the socket. Infra means below. So the infraglenoid tubercle is just a little projection. It's not a landmark we talked about, but it's just a little bony projection from that area just inferior and medial to the glenoid. So the long head originates there and inserts into the olecranon of the ulna, So that's the point on your elbow. So if you flex your elbow and there's that really obvious bony knob there, that is your olecranon. It's part of your ulna, one of the forearm bones. So triceps, all three heads insert into the olecranon of the ulna. So at the glenohumeral joint, then triceps, the long head at least, is going to be an extensor. All right, and so we've reached the end. So those are all the muscles of both the scapulothoracic articulation and also the glenohumeral joint. So make sure you're familiar with the origin, the insertion, and the action of each of those muscles. You should be able to find many of them on the plastic arm, but not all of them. So for example, Latissimus Dorsi is not on there, PEC Major is not on there, your traps aren't on there, those kinds of things. So one of the things to know is that when I ask you about those on the quiz in the lab, the way those will show up is via their origin or their insertion. So in the case of something like PEC Major, one of the things I might do is put a sticker on the intertubercular groove and ask you to name a muscle that inserts there. So you could go with PEC Major, but you could also go with Latissimus Dorsi, or you could go with Teres Major. So if it's not a muscle, it's on the plastic arm. That's one I tend to ask about on the origin insertion stuff. Same kind of thing, I might ask you about a muscle that inserts on the coracoid process, which would be pectoralis minor, because that's not on any of the plastic models either. So that's where a lot of the origin insertion stuff comes in. So other than that, that wraps us up, and we'll talk about the rest of this material in lab this week. So I look forward to talking with you about that.